Normal and abnormal labor and delivery. Labor is a normal physiological process women experience, usually at term, which culminates with the birth of the baby and expulsion of the placenta. Labor is characterized by the onset of regular, painful uterine contractions, progressively increasing in frequency and intensity, and is associated with concomitant effacement and dilatation of the cervix. Two phenomena commonly associated with labor, but not necessary for the diagnosis of labor, are bloody show and leakage of amniotic fluid. Bloody show is the passage of the mucus plug mixed with a small amount of blood. This may precede the onset of labor by hours to days. Amniotic fluid leaks when the fetal membranes rupture. This may happen during labor or precede the onset of labor. Labor is a continuous process, but it has been divided into 3 stages to facilitate its study and understanding, and to aid in its management. The first stage of labor is that interval between the onset of labor and full cervical dilatation. 2 commonly used methods to define the onset of labor are 1. The clock time when painful contractions become regular, or 2. Time of admission to the labor ward in established labor. The first stage of labor ends with full dilatation of the cervix. The first stage of labor is divided into 2 phases based upon the rate of cervical dilatation. 1. The latent phase is of variable duration and is that phase between onset of labor and established labor. That is, from when the cervix is closed at the beginning of labor till 4 centimeters dilatation, after which the rate of cervical dilatation accelerates. 2. In the active phase, the cervix dilates at approximately 1 centimeter per hour. In general, the first stage of labor in multipara women is faster than that in nulliparous women. The second stage of labor is that interval between full dilatation, or 10 centimeters, and the birth of the infant. During this time, the fetus descends through the maternal pelvis, and the expulsion is aided by maternal straining or pushing efforts. The third stage of labor is the time from the delivery of the baby to the expulsion of the placenta. This is usually complete within 60 minutes from birth of the baby, but intervention to facilitate the delivery of the placenta may begin at 30 minutes. The successful culmination of the birthing process is governed by a complex integration between 3 mechanical factors: power, passenger, and passage, the 3 Ps. Power refers to the force generated by the uterine contractions to force the cervix open and push the fetus through the birth canal. These forces can be measured by using an intrauterine pressure transducer and calculated quantitatively as Montevideo units, but this method is invasive and generally reserved for research use only. In everyday clinical practice, we assess uterine activity qualitatively by palpation of the uterine fundus through the maternal abdomen, or by cardiotocography, CTG. The TOCO in cardiotocography refers to external tocodynamometry. The frequency of contractions is measured as the number of contractions in an average 10-minute window, usually 2 to 4 every 10 minutes. In active labor, the contractions increase in intensity over time and last for approximately 20 seconds in early labor and 40 to 90 seconds in the active phase of labor. Passenger refers to the fetus, and there are several fetal variables that can affect the course of labor, such as size of fetus. Small fetus negotiate the birth canal readily, while large babies could lead to cephalopelvic disproportion. Lie. The long axis of the fetus relative to the long axis of the uterus, which is often dextrorotated. Fetal lie can be longitudinal, oblique, or transverse. Presentation: the part of the fetus that directly overlies the pelvic inlet. It is usually cephalic, breech, or shoulder. The position of the fetus is the relationship of a nominated site of the presenting part of the fetus with respect to the denominating location on the maternal pelvis. When the fetus is in a vertex presentation, the position of the fetus is a description of where the fetal occiput is in relation to the maternal spine. To understand the implications of fetal position on the labor process, it is important to know the diameters of the fetal head as shown below. The suboccipitobregmatic diameter, which measures 9.5 centimeters, is the presenting diameter when the fetus is in the flexed occipital anterior position, and this position is most favorable for a vaginal delivery. The occipitofrontal diameter measures 11.5 centimeters and is the presenting diameter when the fetus is in the occipital posterior position. Occipital posterior position is associated with prolonged labor and increased rates of cesarean and instrumental delivery. The mentovertical diameter is the largest diameter of the fetal head, measuring 13.5 centimeters, and is the presenting diameter in brow presentation. Vaginal delivery of term fetuses in brow presentation is not possible. The submentobregmatic diameter measures 9.5 centimeters and is the presenting diameter in face presentation. Vaginal delivery of a fetus in face presentation is possible only if the presentation is mentum anterior, where the fetal chin is able to pass under the pubic symphysis by further extension of the fetal neck. The fetal station refers to the degree of descent of the leading edge in the presenting part of the fetus, approximated in centimeters from the ischial spines, example 1 to 3 centimeters above or 1 to 2 centimeters below the ischial spines. These are annotated as -3 to -1 and +1 to +2 respectively. Fetal anomalies such as hydrocephalus or a sacrococcygeal teratoma could lead to an obstructed labor. Passage comprises the bony pelvis and the soft tissues of the uterus, example cervix and pelvic floor muscles. The bony pelvis can be gynecoid, anthropoid, platypeloid, or android. The gynecoid pelvis is the most common pelvic shape and is best for vaginal delivery. The platypeloid and android pelves may lead to obstructed labor. Mechanism of labor. Engagement happens when the widest diameter of the presenting part passes below the plane of the pelvic inlet. In a cephalic presentation, this would refer to the biparietal diameter. It is generally measured as fifths, palpable above the pelvic brim, and the head is said to be engaged if 2/5 or less is palpable abdominally. Descent refers to the downward passage of the presenting part within the maternal pelvis. Flexion of the fetal head happens as the head meets resistance against the pelvic floor muscles and the head pivots about the atlantoaxial joint. This allows the presentation of the smallest sagittal diameter of the fetal head, the suboccipitobregmatic diameter. Internal rotation of the fetal head occurs passively, from a sagittal transverse alignment of the fetal head at the pelvic inlet in the maternal pelvis to a sagittal anteroposterior orientation at the pelvic outlet. This happens passively as guided by the slanted bowl shape of the pelvis, which points downwards, inwards and forwards, and the similar orientation of the sling of pelvic floor muscles. Extension of the fetal head occurs once the fetus has passed the resistive forces of the pelvic floor musculature. Continued uterine contractions and maternal expulsive efforts continue to provide downward pressure onto the fetus, and the birth canal has an upward curve at the very end. Once past the introitus, also known as crowning, the fetal head extends to return to its neutral orientation with respect to its spine. External rotation and restitution. Within the pelvis, the fetal shoulders reach the pelvic floor and begin its rotation from the transverse position into an anterior-posterior position. To restore its normal orthogonal relationship with the shoulders, restitution of the fetal head occurs. This involves the external rotation of the fetal head by 45 degrees to face the right or left medial thigh of the mother. This is an active movement by the fetus carried out after all resistive forces by the maternal pelvis and pelvic floor musculature have been removed. Expulsion is the delivery of the rest of the fetal body, first with the anterior shoulder of the fetus just below the pubic symphysis, and then by a sweeping motion towards the maternal abdomen. The posterior shoulder and rest of fetal torso is delivered. Delivery of the placenta and perineal repair. After the baby has been delivered, the umbilical cord is cut between clamps. The mother is usually administered an intramuscular oxytocin to cause uterine contractions and facilitate the delivery of the placenta and prevent the likelihood of postpartum hemorrhage. The placenta is then delivered by controlled cord traction by the Brandt-Andrews method to reduce the likelihood of uterine inversion. At the time of crowning, the perineum would commonly tear, or a mediolateral episiotomy might have been made just prior to crowning. These are repaired using a rapidly absorbable 2-0 suture. Pain management during labor. Some women prefer a medication or analgesia-free labor. These women would benefit from adequate psychological preparation, continuous support throughout the labor by the partner or trained professional, and relaxation techniques such as meditation, massage, immersion in water during the first stage of labor, and acupuncture. Alternatively, there are different measures for pain control of varying degrees of success, such as transcutaneous electrical nerve stimulation, Entonox, a 50-50 mixture of nitrous oxide and oxygen, colloquially known by midwives as gas and air. Opioids such as pethidine, morphine, and fentanyl could be used, but may cause respiratory depression in the neonate if given too close to birth. Epidural analgesia is a popular medical pain control method in hospitals where regional anesthetic services are readily available. It is an effective form of pain management that is not associated with an increased risk of cesarean section or depressed APGAR scores. Induction of labor. In some circumstances, example insulin-dependent diabetes mellitus, it is preferable that the baby be delivered by 38 weeks amenorrhea. Often, labor would not have started spontaneously by then. Labor can then be induced to start by the use of vaginal prostaglandins, artificial rupture of membranes, or intravenous oxytocin. Depending upon the Bishop's score or cervical score, any of these could be used alone or in combination to start active labor. Labor could be prolonged in either the first stage or the second stage. It may occur due to poor uterine contractions, persistent occiput posterior position, or cephalopelvic disproportion. It is less common in multipara than in nullipara women. The use of oxytocin to augment labor may be appropriate action for the first two conditions, but could be dangerous in the presence of cephalopelvic disproportion and cause a uterine rupture. Therefore, the use of oxytocin in a laboring woman must be done only after careful evaluation of the full clinical picture and a reasonable assessment of the underlying cause of delay. Thank you for watching this video. This video is presented by Yongloo Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.